This is my name, and you know, I'm a child neurologist at Mafraq Hospital. I did my training at Ohio State University, Nationwide Children's Hospital in child neurology, and I did my pediatric training in Texas Tech University at Amarillo, Texas, and I did a touch of hematology oncology, like only 14 months. Then I moved to child neurology. We're going to talk today about cerebral palsy. The first thing we're going to start with is what is cerebral palsy. In 2005, a committee of the American Academy of Cerebral Palsy and Developmental Medicine, AACPDME, led by Peter Rosenbaum, defined CP as a group of disorder, so it is not one entity, of the development of movement and posture causing activity limitation that are attributed to non-progressive disturbances that occurred in the developing fetal or infant brain, right? So it is non-progressive. This is why I underline it. If it is getting progressively worse, it is not CP. The motor disorders of cerebral palsy are often accompanied by disturbances of sensation, cognition, communication, perception, and or behavior and or seizure disorder. So cerebral palsy, you can diagnose the patient with cerebral palsy, but you need to look at what else he has. We are dealing with the consequences of cerebral palsy. Okay, next please. And in the 6th edition of the International Classification of Diseases Handbook, there are over 50 different classifications of CP. The incidence of CP is considered to be 2 to 2.5 per 1,000 live births, and the diagnosis usually involves waiting for the definite and permanent appearance of specific motor problems. So don't diagnose CP by 4 months of age or 3 months of age.
Okay.
Why? Anyone know why? Because the main output from the brain is mainly inhibitory for the first 6 months. And a lot of the time you will see the patient, you examine him, he's hypotonic. Even though you look at the MRI, he has severe hypoxic ischemic encephalopathy. But because the main output is inhibitory, you need just to keep following up them, and by the 1 year old, you will find a lot of spasticity, and the signs of hypertonia will appear. Next, please. Now, what are the clues to diagnosis of cerebral palsy? Delayed milestones. Usually the kids would not be meeting his milestones. Persistent of a primitive reflexes. What are the primitive reflexes? You guys know? Moro, asymmetric tonic neck reflex, sucking reflex, grasp reflex, rotting reflex, starter reflex, and failure to develop protective reflexes such as parachute response or asymmetric movement. We love asymmetry in neurology. People who are symmetrical are not really exciting for us. If people who are skewed or asymmetrical, we love them because we know where to go, right? Where's the abnormality? So asymmetric movement, when you are watching the kid and the kid is kicking with his hands and legs, and he's not kicking as hard with his right leg, just like the left leg, then you know there's some problem, right? So asymmetry is very significant. Now, no progressive neurological diseases and no loss of milestone should be present. Why? Because if you see progressive neurological disease or loss of milestone, what are you going to think about? Neurodegenerative disorders, right? So this one will take you to another route or another highway of your evaluation, and also will take a different prognosis. CP kids are usually improving slowly, or they are static, not improving, and sometimes they have pseudo regression, but because of the development, for example, of the hypertonia when they reach the 1 year of age, most of the time. That is why you have to be aware of a change in exam that may result from growth and maturity. Okay? Now, it is not unusual for a child with cerebral palsy to have hypotonia initially and then hypertonia. Why? We just said that. However, if a child has hypertonia initially and then become a hypotonic. A neurodegenerative disease should be searched. Like what? Give me just 2 examples. Metachromatic leukodystrophy. It can affect the central nervous system, so they become very stiff, and then hit the peripheral nervous system, then they become hypotonic because we damage the nerves. Krabbe disease, another example. Okay?
Molybdenum cofactor A deficiency.
We'll talk about this later on. It's a neurodegenerative disorder. That's a good example. Classification of cerebral palsy. There is 70% of cerebral palsy are spastic, and you know spasticity. There is cogwheel rigidity, and there's a clasp knife spasticity. The typical clasp knife spasticity is secondary to pyramidal system, whether in the motor cortex, corticospinal tract, spinal cord. The cogwheel rigidity, or what we call rigidity, is usually sign of what? Extra-pyramidal system, like in Parkinsonism, cogwheel rigidity. Now, what is the spastic cerebral palsy? You divide them in bilateral spasticity, unilateral, and bilateral is the most common spastic diplegia. Why? Because of prematurity. That's a lot of the time a question. The commonest is spastic diplegia. Why? It is more prevalent in premature because of what? PVL, periventricular leukomalacia, right? And where is the legs reside? In the paracentral area, right? This is where the motor cortex, if you look at the homunculus, the legs will be hanging in the medial side, right? So that's why a lot of the time you get hit in that area. Spastic quadriplegia is the more severe form. Usually we see it in the hypoxic ischemic encephalopathy. Unilateral spasticity, spastic hemiplegia, a stroke. Most common in this form is the seizure. Monoplegia and triplegia, I have probably 2 or 3 patients of each, and it is uncommon, right? Now, spastic hemiplegia, stroke, spastic diplegia, prematurity. Now, the extrapyramidal or dyskinetic cerebral palsy is 10 to 15%. And it can show up like bradykinesia, which is what? Slow movement, okay? Dystonia, abnormal sustained posture, right? Choreoathetosis, what is chorea? Rapid jerky movement. Athetosis, slow riding movement. And hemipalismus, abnormal flailing movement of one side of the body. Now, choreoathetosis, the most common cause for choreoathletic disorder is kernicterus. It does not happen as much nowadays because we treat them with the phototherapy, exchange transfusion, so we don't reach to that level. Now there's the hypotonic, there's ataxic, and there's mixed form. Now, you know, a lot of the time you can have a spastic diplegic kid or who is wheelchair bound, he cannot move at all. And in another patient, you can have spastic diplegia, but the kid can move and even can run. How can I classify them? And we can talk the same language. Okay, if I tell you novizagikipa, are you going to understand me? Because, you know, we are not speaking the common language, right? That's the same way they developed the gross motor function classification system. This is to help, you know, the physician when they put the patient in this level, the physician right away, spastic diplegia in this level, yeah, I know how bad is his CP. For example, GMFCC for children aged 6 to 12 years of age, description and illustration. Level 1 is basically, level 1 is the kid almost, you know, is functional. He moves by himself. Level 2, he might need some assistant. Level 3, of course, he need more assistant, like in a wheelchair, but he can operate that. Okay, he can use the crutches. Level 4, you can also. Level 4, you need more assistant, wheelchair bound. And level 5 very much completely dependent on his family, right? Okay. Causes of cerebral palsy. What is the commonest cause of cerebral palsy? Prenatal cause, 75 to 80%. And 75 to 80%. These are areas I highlighted. There are common questions for you guys. congenital abnormality, whether it's the first trimester or is it in the second trimester, in the first trimester genetic, chromosomal, brain malformation, second or third trimester, intra-infection, intrauterine infection, problems in fetal or placental function. Cause of cerebral palsy: perinatal 10 to 15%, postnatal 10%. If the patient is riding in the car, dancing, and all of a sudden the dad pushed the brake, right, and he hit his hip and develop bilateral injury and become spastic, and they have a patient like this, you still can call it spastic cerebral palsy, even though it's a postnatal, but that's not as common. And not obvious cause is 30%. Now, if you go back, prenatal is 75 to 85. Perinatal, 10 to 15. How much now? Almost 90?
Yeah.
Postnatal, 10%. Not obvious, 30%. So it's 130%. 130% about 1%. It's not because we are in the mafraq and we are generous. Of the obvious cause, we know that is it's the classification, and 70% we know what's the cause, right? And it's classified as 75, 15, and 10, and 30% we don't know what's the cause. And we are going to talk about this because you really have to pay attention to that not obvious cause. Next. Differential diagnosis of cerebral palsy. And here, if you have a patient who does not have classical finding of cerebral palsy, no hypoxic ischemic encephalopathy, there is no prematurity, and the kid is spastic, then you need to think of other disorder. Inborn error of metabolism, urea cycle defect, biotinidase deficiency, homocysteine, demethylation defect, cerebral folate deficiency, cerebrotendinosis xanthomatosis, dopamine synthesis defects. This is the inborn error of metabolism that can come or present as spastic cerebral palsy and can mimic that. Tetraparesis with ichthyosis. If you see a kid who quadriplegic and he had ichthyosis, skin abnormality, Sjogren-Larsen syndrome, okay, and multiple sulfatase deficiency, and you can see this is how you can test for these disorder. Neurodegenerative disorder, Tay-Sachs, leukodystrophy, Rett syndrome, hereditary abnormality, trisomy 13, 18, hereditary spastic paraplegia, familial dystonia, Dober-Spencer dystonia. Do I expect you to know that? No. Do you want to keep them by heart? Please don't. Because you need to keep them in the back of your mind, and when things look at the MRI is normal, no history of HIE, no history of prematurity, and the kid is not doing well, losing milestones, is something fishy, then I have to keep them in the back of my mind, okay? Now, what are the test or the checklist of lab tests in spasticity? What do I need to do? What do I need to check the kid if he does not have the typical finding or the typical history of patients with cerebral palsy? Then these are the lab tests you need to do on the right side. We just mentioned the disorder. These are the lab tests you need to do on the C5 neurological disorder, C5.12 table. Again, please don't keep them in your heart. Just keep them in your mind that there's not every kid who is spastic, this is cerebral palsy. Just keep open mind. Now, looking at the differential diagnosis of cerebral palsy, this table tell you what are other things that might help you to tell you what is the cause of the cerebral palsy or what look like cerebral palsy. For example, if you have peripheral neuropathy, you can think of, for example, mitochondrial disorder, biotinidase deficiency. You can think of metachromatic leukodystrophy. If you have leukoencephalopathy, that's the other disorder you need to think of. Ataxia, cerebral folate deficiency, an example. So this is more to help you, direct you to the workup of which disease that might look like cerebral palsy or might cause cerebral palsy. If you see a kid with cerebral palsy with abnormal eye finding or ocular signs, then you need to go through the list and look through these disorders that might look like CP, okay? Remember, check nerve conduction, visual, auditory function test, auditory function, skeleton examination, urine glycosaminoglycan, oligosaccharides in patient with multiple neurological signs and progressive spasticity. Some brain MRI specific pattern can give the diagnostic clue. Consider the possibility of a brain iron disorder in a patient with a progressive spasticity, especially if episodes of regression are triggered by infectious event and even the absence of a specific brain MRI finding, basal ganglia involvement, and the finding is called eye of the tiger. Okay? Again, this is basically more for me to remember and to keep it in my mind as a child neurologist, not for you guys as to remember. Okay? Now, important practice points. I have a patient who has cerebral palsy, and you know, the things that I need to keep in my mind a lot of the time is the prognosis. What is the prognosis for this kid? For example, from the age of about 2 years, it is possible to predict likely motor outcome, and advice can be given about the likelihood of independent walking or whether the child will be wheelchair dependent. If you have a kid who's 2 years of age, just like the kid they saw today, and she starts to walk, you know, she has diplegia, you can tell the family most likely she will be walking, and most likely she will walk independent. Okay? If you have a kid at 2 years of age and he is completely encephalopathic, and he has quadriplegic cerebral palsy, you will tell the family most likely he's not going to walk. And even if he's going to improve, it is unlikely he's going to walk. Is there an exception? There's always a lot of exceptions. Okay? You need to ensure up-to-date immunization, very important. One that we almost always forget, yearly influenza vaccine, is very important. You have to do regular hip surveillance. Why? To prevent secondary problem of subluxation and dislocation. And when do you have problem with the hip in patient with CP? Because you have tight adductors, okay, and tight muscles, and the head of the femur are not pushed against the scapula, so it does not develop very well, okay? Consider the need of the family. For example, has a suitable lifting equipment between equipment provided to the family. A lot of the time the family will come to me and tell me, doctor, I need just a parking permit. I really can't park my car like 200 meters from the hospital and carry my kid on my back to bring him to the hospital. Things as small as that can make a huge difference in patient care. And believe me guys, a lot of the time the family, they come to you and they know that their kid is not going to be normal, but they want their life to be, you can smooth their life and you can let the kids be independent as much as you can. Now, when a child with CP presents with pain or irritability, consider the following possibility. Recurrent infection, especially UTI, dental disease, because a lot of them have poor dental hygiene, especially in our countries here. Pathological fracture. Why do we get pathological fracture? Because they are a lot of the time laying down, they are not moving, and they lose calcium from where? From their bone, okay? And also they are a lot of them, they have seizures, and they are medication for seizure. And seizure medication, what would cause for you? You lose more calcium, right? So always keep this in mind. Gastroesophageal reflux disease is very common, and a very common cause of irritability, constipation, really common. They do KUP and read it yourself. Renal stone, and one of the commonest trigger also for renal stone in kid with CP and seizure, tobramate, right? Why? Why tobramate can cause renal stone? It's a carbonic anhydrase inhibitor, right? Just like what? Acetazolamide. Good. Subluxation and dislocated hips, you should be doing surveillance every time. Sleep deprivation, which can cause pain or spasm, and it can be very stressful for the family. So give them medication to sleep. Start with melatonin, for example, and see if this is going to help them. If not, you can move to other medication like clonidine. You can use that. Neurontin, you can use that. And you can also use like sometimes benzodiazepine to let them sleep. Increased intracranial pressure. A lot of the kids, they will develop hydrocephalus and they need a VP shunts. So if the kid with CP come with seizure and fever, always with VP shunt, always pay attention to the VP shunt. Non-accidental injury. These kids are at higher risk for abuse. Well, yeah, they need a lot of work. and not everybody is patient, and not everybody has the capacity to to deal with these kids. So they can get mad and they can abuse them. We have seen disasters in the Western country. Changes in home environment, school, or family that might be impacting on well-being also can cause can cause a problem for the kids. And remember, the normal kids, when you are at a high stress situation in your life as a parent, you tend to ignore them. Sometimes you need to take care of other things. These kids, they tend to be ignored more. Sometimes they forget to give them the medication. Sometimes they are in baclofen, they tend to stop giving them the baclofen because they forget about it, they are very busy, and the kid comes with severe spasm and pain. Now, how can I manage the consequences of the motor disorders? The main problem is with me is spasticity. How can I treat spasticity? You can use benzodiazepines. You can use baclofen as oral medications for that. And sometimes you can use tizanidine for spasticity. That's very helpful to relax, the muscles. A lot of the time, if it does not work, and if you have less than 4 large group of muscles, you can use what? Botox or botulinum toxin. What is the mechanism of action of Botox? Who's the other one interested in neurology? Presynaptic release of acetylcholine, right? Block the presynaptic release of acetylcholine, right? And if the patient the kid is like more than 3 or 4 years of age, he is spastic all over, he's not responding to medication, or the medication are causing him a lot of trouble, what can we use for him? Baclofen pump, right? And it can be very, very helpful, okay? Now, drooling can be improved with medication. Like what? Anticholinergic. Propanol, right? Glycopyrrolate, the same medication. You can also do what for them? You can give them Botox in their parotid gland. So this gland will dry, the parotid gland will dry, and the other gland will take over. So that will help a lot. Incontinence, a lot of the time, you need to make sure they are not over impacted, okay? And they are moving regular bowel movement. And if they have, that will a lot of the time help with incontinence, whether it's a bowel or bladder. The trouser overactivity may cause urgency or frequency. We can give them medication, again, anticholinergic medication. Detropan can be very helpful for this. Undescended testes usually require fixation by surgeon. The thing that you really need to pay attention, you might examine the kid at birth, and the kid is not hypertonic, the testes are normal. When they grow up, they go up. So you need to keep examining these kids, okay? Orthopedic problem. Surgery is mainly undertaken on the lower limb, but is occasionally helpful for the upper limbs, okay? And usually we like to do the surgery when the kids are almost around puberty. Why? Because a lot of the time the kid, they will do tendon lengthening procedure, they stand up nicely, and 2-3 years later they develop contraction again. So you give them Botox, aggressive physical therapy, until they get as close to puberty as possible. That will help a lot, to cut down the number of surgery, and also cut down the number of complications, and tend to be more of definitive treatment. Physiotherapy, extremely important. I just had a patient today. You cannot believe that she has spastic diplegia. She has a full range of movement because they have aggressive physical therapy. Okay? We talked about the hips. Now, early detection of hip problem can be very helpful, and you also need to do surveillance for scoliosis. Next, please. Scoliosis, sometimes you need to give them, to do surgery for them. I usually refer them to orthopedic surgeon who knows how to deal with scoliosis. Spasticity, we already talked about it. And just to highlight that, in addition to the oral medication or the botulinum toxin, baclofen pump, selective dorsal rhizotomy can be done. And nowadays, they can go into the gastrocnemi bilaterally here. in the muscles, and they can open it and they can denervate half of the muscle, and that can be very helpful for toe walking. Okay, next. What kind of cerebral palsy is the first one? Diplegia, right? So you are mainly involved where? In the lower extremity. You can be affected in the upper extremity, but it is not a must. Hemiplegia, you are affected on one side. What is the commonest cause for that? We just said that. Stroke. And this is the most common form associated with seizure. Diplegia, what's the most common cause? Prematurity. And quadriplegia, hypoxic ischemic encephalopathy, and it is the most severe one. Okay, next. What is this a posture? What do you call this posture? Okay, sit on the slide. Spastic quadriplegia, characteristic scissoring position of lower limbs due to adductor spasm, right? That's scissoring. So you tend to hit the adductor with Botox, even though with quadriplegia we tend like to use oral medication because you have a lot of muscle involved, okay? And or baclofen pump. That would be more helpful, okay? Next. What is this one? Hemiplegia. Okay. Next. What is this one? Athetoid cerebral palsy. What is the most common cause for athetoid or chorioathetoid cerebral palsy? We just said that. Kernicterus. Do we see it a lot nowadays?
No.
Excellent. And what is chorea? Rapid jerky movement. Athetosis, slow riding movement. Okay? Next. Ataxia, ataxic cerebral palsy. How do you define ataxia? It's wide-based gait. Just wide-based gait. Regardless what is the cause, it's wide-based gait is what you call ataxia. Okay? Next. Diplegia, we talked about that. And one thing, remember, see, in the quadriplegia, you have scissoring, right? Because the adductor are hit very bad. But in the diplegia, even though the lower extremity are involved, you don't have much of adductor spasm. Next. Now, again, we said the cerebral palsy is not the end of your problem. You need to do a lot more surveillance. You have to send them for the eye doctor to see how they are doing with their vision. You need to send them for hearing. Okay? You send them for language, if they need speech therapy, for speech therapy. And sometimes you assist their cognition if they need to. And some of the kids with diplegia are very smart, or kids with cerebral palsy, and some of them are mentally retarded. So you need to be aware of the overall status of the patient. Next. Treatment for cerebral palsy. Is there a cure? No cure. Physical therapy, occupational therapy is very important. Braces, mobility tools, extremely important. Benzodiazepine for decreasing spasticity. Baclofen pump, treat constipation, healthy diet, Botox injection. If you have less than 4 large muscle groups, lengthening of tendons, we tend to wait until they are as close as they can to puberty, Dorsal rhizotomies, we don't do it as much, but sometimes very helpful. And epilepsy, almost you can have children, so you need to be carefully treating the epilepsy and educating the patient about that. What is the general prognosis for cerebral palsy? Mixed spastic and extrapyramidal cerebral palsy almost never resolve. Spastic hemiplegia almost walk by 2 years. Spastic diplegia more than 50% walk by age of 3 years. Spastic quadriplegia 33% walk by the age of 3 years. Conclusion: cerebral palsy is a diagnosis of pattern recognition. Cerebral palsy is associated with a condition called pseudodegeneration, especially at the time of puberty, or at the time when you are moving from the main inhibitory output from the brain to normal output in the first year. That would look like pseudo-degeneration. The mom will tell you, the kid is getting more spastic because the effect of inhibitory output from the brain is getting less in the first year. And accurate diagnosis is important for genetic counseling. Guys, we had family with 3 kids. 3 kids with the same disorder because the first kid was not diagnosed well. And the last patient I saw that broke my heart, the kid is almost normal. She has only have a little abnormality when walking. We did the MRI of the brain. It's almost normal. We tell the mom she got the disease. What is the disease? It is MLD, and the mom knows the kid will be devastated, and she will follow the same path like her sisters or her siblings. So she was devastated. So when you diagnose early and you tell the family this is an autosomal recessive or X-linked, your chance 1, 2, 3, 4, 5. You know, some of the families said, you know, I have 3 kids and they are, thank God, they are healthy. I don't need to get more. But if you don't do a right diagnosis, you end up with a family with 5 normal kids, 3 normal kids, 2 normal kids, 3, 4 dying. You know, no matter what is the disease, it's always horrible for the family.
Yeah.
Next. This is Alsayouf cerebral palsy. She does that all the time. Slow random movement with her hand. So this is called Alsayouf cerebral palsy. And this what is what? Spastic cerebral palsy. Most likely diplegic cerebral palsy. And look at the legs. What we call this with this gait? No, not scissoring. Scissoring crossed legs and quadriplegia. It is circumduction gait. They move the legs out. Circumduction gait.